Well, thank you for joining us on a Sunday, nonetheless, for this very special 40-year anniversary celebration of the UCLA Adult Congenital Heart Center. I'm Jamil Abelhosen, for those of you that don't know me, and the lady seated to my right here really needs no introduction. This is Pam Miner, nurse practitioner at the UCLA ACHD Center for 29 years, who thought she retired about 2 months ago, but in reality, her retirement turned into actually being the chairperson for this wonderful program that we've put together for you today. We would have loved to do this in person and had our patients and their families and our colleagues all together for this event, but it is 2020 and it's the time of COVID, so unfortunately we couldn't do that. And therefore, we've gone in a little bit of a different direction here, and we've put together a photo montage, some documentary types of things for you, including in-depth interviews with legacy providers, legacy patients, those that were there at the beginning of the adult congenital program, and those that you see now when you come in to see us. For those of you that have not been touched by congenital heart disease but are tuning into this, we hope that this gives you a perspective into our world and the way we approach what we do, and the way this congenital heart disease program has grown over the last 40 years and has really defined milestones for the field as well. So without further ado, I'll pass it to our chairwoman, Pam Miner.
Thank you, Jamil, and thank you for everyone being here. It truly has been a labor of love to put this presentation together, and for me personally to reflect on the last 40 years of adult congenital heart disease, having seen so much of the development of this specialty firsthand. So Jamil and I will guide you through this program. We have 7 short segments, including these interviews, that we will introduce to you as we go along. And at the last half hour of the program, once we finalize the formal program, you'll have a chance to ask questions, and we have some stellar faculty and staff that are here in our audience today, socially distanced, that will be available to answer questions. Dr. John Child, our emeritus director, will be here. Mary Canobbio, our founding clinical nurse specialist, and Dr. Gentian Lurie, Dr. Lee Reardon, Dr. Jeanette Lynn, and Linda Hauser will be here as well. So we hope that you'll have some questions. The chat function on the screen today, you'll be able to interject comments or questions. We'll try to get to as many questions as we can. And there'll be a way to kind of come back to this presentation on our website later on. So we'll give you a little bit more detail about that as we go along. But we're going to start with a beautiful photographic montage that really shows you each decade of the last 40 years, including milestones that were important to those decades. So please enjoy this. That was amazing. Brings tears to my eyes every time I see it. But thank you, special thanks to Linda Hauser for doing all the work of pulling those photographs and those history guideline milestones together and creating this beautiful montage. And for the other montage photo series you'll see in this presentation, she also created those. So thank you, Linda. No journey through the history of adult congenital heart disease at UCLA would be complete without a special tribute to Dr. Joseph Perloff, our founder. So this first segment will really reflect on him and what he brought to the specialty, really as our founder. And the opening interview is actually of him, and it was filmed in 1998, which was a great way to start this segment. So we'll go ahead and roll that.
The center, which is devoted to the increasing adult population with congenital heart disease, is a combined facility of the departments of medicine, pediatrics, and surgery.
When I first encountered Dr. Perloff, I already knew that this was a field that attracted me. While I was in the Navy, I had read his complete book on the clinical recognition of congenital heart disease. And I was attracted in particular to the almost Sherlock Holmesian nature of taking pieces of information from the history, the exam, electrocardiogram, chest x-ray, and so on, and sorting each piece of that information, putting it together, and trying to surmise what this person had, what they needed done for them. And so I already knew that I wanted to be like this person. It just was fortuitous that he came to UCLA near when I got here, because I didn't know that. That wasn't the reason I came back to UCLA. I already had arranged for a spot to come back to on the faculty when I left the Navy, because I had already been here, they knew me, and I wanted to come back when I was done. I mean, I could have just as easily made a career in the Navy doing cardiology, but I felt that the avenues that I would enjoy were broader by being back at UCLA.
You know, I didn't meet Dr. Perloff until I had finished my general cardiology training and come up to UCLA to do my adult congenital training. But I knew of Dr. Perloff for many years before, and I had actually read his textbook cover to cover probably 3 times by the time I first met him. So I could sort of quote his work. I loved the way he wrote. He kind of writes and speaks in this classic, almost post-war 1940s, early 1950s style. And, you know, when I met him, I kind of knew the kind of man he would be. He turned out to be exactly that. A very intellectual man, extremely bright, deep knowledge of not just congenital heart disease, but all sorts of stuff. He was a voracious reader. It was a real joy to spend my early years at UCLA working with Dr. Perloff. We had a teaching clinic together that we did for maybe a year and a half, towards the very end of his career. He was already retired at that point, but would come in to do the teaching clinic, and I found myself really enjoying the time that I spent with him, the focus that he had on the physical exam and on diagnostic testing. In the end, he was also just very kind and very welcoming to me, as was his family. And you know, over the years, we built a close friendship, one that continued until really the very last days of his life, and has continued with his family thereafter. I must say that my getting to know Dr. Perloff and getting to know him not just as the Dr. Perloff that everybody speaks about, who founded the field and writes all of these textbooks, but getting to know him as a man and as a friend really opened my horizons and told me that, again, you know, one can approach this field in their own way, just like Joe Perloff did, and be very successful, but you just have to know what you're doing. Joe was a brilliant man and a lot smarter than a lot of other people around him. He knew how to take extremely difficult to understand information, complex anatomy, complex physiology, and explain it in a way that the rest of us could understand it and then explain it to others. And that's been his gift, I think, in the long run, is through his books and through his written word that has survived and will continue to survive. And I think his work will be even more valuable in the future than it has been in the past.
Joe Perloff was such a visionary. He was influenced by Paul Wood in London. And Paul Wood was the consummate diagnostician, clinician, hands-on, loved the jugular venous pulse. He really instilled a passion in many people on the physical examination of the heart. Well, you know, regular acquired heart disease is pretty boring, but congenital heart disease had all kinds of findings. They were just, people were blue, they were clubbed, they had different heart sounds. And so people who really loved novelty and loved physical exam were kind of drawn to congenital heart disease. Joe Perloff was one of his mentees.
Well, that was a wonderful segment. You know, Dr. Perloff was such a visionary, and the field would not be where it is had it not been for his vision. As far back as the late 1960s and early 1970s, he was making statements that this field needs to be founded. And in that 1973 American Heart Association lecture that was referenced earlier, that is a real milestone that we look back at as the time when a flag was placed in the ground that this field needed to be founded. And he came to UCLA thereafter, and he did exactly that. And we're all blessed for him doing that. I want to also thank Dr. Perloff's family. His wife, Professor Marjorie Perloff, his daughters, Nancy and Carrie. I know that they're watching among, as well as other family members. So thank you for joining us, and thank you for all the support that your family has given to the center for all these years. And thank you, frankly, for sharing your husband and your father with us for all of those years. Next, we will have a segment on the early years of the program with interviews with our legacy providers that were there on the ground back in the 1980s when the program started. So let's go ahead and roll that.
We had such a perfect partner with Joe Perloff, who had come to UCLA about 3 or 4 years before me and had established the Adult Congenital Heart Center, which was absolutely fantastic and groundbreaking. I was probably the only one in cardiology at the time that had experience with adult congenital heart disease, because in Boston I had been taking care of fetuses and children and adults as old as 50s with congenital defects. It was wonderful to be able to work within the clinic that Joe had established, and Joe Perloff and John Child, and I think Jamil was a fetus at that time, but then when he came into full maturity, it was just a progression of wonderful people in the Amundsen Adult Congenital Heart Center.
And we came together about what kind of a program do we want to have for these patients? And one of the key things that we came up with is that it wasn't going to be a clinic per se. There would be a clinic where patients came, but this is about a program. And Dr. Perloff had a vision, and it included patient care, it included research and education and training. Now, our adult clinic, the program started with the support of Dr. Arthur Moss, who was recently retired. He had been the chief of pediatrics and a cardiologist for many years. And I remember that when we started organizing the program, Dr. Perloff gave me a little wooden box of index cards, and in there were about 400 names, and Dr. Moss had given those to him. So we set about sending letters to these patients and telling them that they needed to come back to clinic, but it was because they were adults, they had to come to the adult side. And that's how we started.
I think the fellows began to enjoy this whole area much more as time went on and they saw what we were doing in this clinic. I must say that at the beginning they didn't all flock to this clinic, and I think they shared the same viewpoint that the overall faculty felt, that this was really something best left to pediatric cardiologists or their cardiac surgeon for follow-up of this. But as we pieced together the information and displayed it for them, we'd bring the echocardiographic reading machine up to the clinic so they could see each patient's echo in front of them rather than just reading a stale report. They, I think, got attracted, and I think the imaging is an important part of this. In other words, it's not just talking to the patient, which it should be, but seeing that sort of data explained to them, making it more instantaneously important for the patient you're seeing right then. It attracted a lot of the fellows that we had. And then ultimately, when it became a center and therefore had some level of gravitas and was no longer, quotes, a boutique, some of the fellows became attracted to, if not becoming like us, to at least spending more time on rotations with us.
Yeah, I was at the time at Yale for about 5 years, director of pediatric cardiac surgery, but spending about half my time also on adults. At the time, Bill Glenn, the person who created the Glenn shunt, was still on the faculty, although not doing cardiac surgery. And I was approached to come for an interview at UCLA. At the time, they were doing about 30 pediatric cases and about 200 adult cases. And that gave me some concern as the challenge to build that up. And then I met Joe Perloff, and Joe had already established the Adult Congenital Heart Clinic and had this tremendous enthusiasm and drive to really make something of it and create this as a major center. And I was very much attracted by that, and I saw tremendous potential. He already had the largest adult congenital heart clinic in the United States and perhaps in the world at that time.
When I look back and reflect on those patients who we lost, either because we did a surgery that they didn't survive or because they died suddenly and unexpectedly as an outpatient, I often think, wow, if they were alive now, their outcome would be completely different because what we do is so much better. But I also look back and think, wow, those are the people that drove us to make these improvements. There are lots of successes, lots of congenital heart patients who now have children, women and men, and who are parents, and they look like every other parent, and they don't think of themselves as the parent with congenital heart disease. They think of themselves as the parent of their child. And that's something that 30 or 40 years ago was not within their reach. And now it's not only within their reach, it's an expectation.
My name is David Atkinson. I was born in Los Angeles as a blue baby. I was born with a single ventricle, specifically with a double inlet left ventricle. Dr. Moss became my pediatric cardiologist, and when I was 11 months old, I underwent a Blay-Lactowsic shunt. I did pretty well with that. My parents restricted me some, but not a lot. I was the youngest of 5 kids, so I got lost in the shuffle a lot, so I was able to do pretty much most of the things I wanted to do. But I remember when I was at UCLA, when I was about 20 years old, Dr. Moss told me at one of my clinic visits that he was not going to be my doctor anymore. There was a doctor coming from the East Coast who was specialized in adults with congenital heart disease, which was unheard of at that time. There was no other clinics like that in the United States. And he came to UCLA, and I remember meeting Dr. Perloff in Dr. Moss's office in the Marion Davis Children's Center at UCLA, and being very impressed by how intelligent he was. And I know if anybody who remembers Dr. Perloff, he would speak in these sentences that were like they were taken from a textbook with parenthetical asides built into them and things like that. And he was just a very impressive mind, but also a very compassionate man. And I was one of the, I guess, founding patients at the Adult Congenital Heart Center at UCLA.
There really wasn't a body of pediatric cardiologists at the time. And so people who liked congenital heart disease sort of stuck together. The pediatric cardiologists and the adult cardiologists who were interested in physical findings. And then as the field grew of congenital heart disease, so we started to have more techniques to study it. We started to recognize the natural history of lesions. And of course, even in the very early days, there were still survivors of tetralogy of Fallot, coarctation of the aorta occasionally, aortic stenosis, pulmonary stenosis. So we had a lot of these people who were living well into adult life. And it was sort of the combined joy of both pediatric and adult cardiologists who did all their conferences together, worked together.
I've been involved in adult congenital heart disease in some form or another since the mid-1990s. There were luminaries in those early days. Joe Perloff, Jane Somerville from London, David San from Oregon, Gary Webb from Toronto. I spent more than 2 decades in Toronto, a place where there's a captured audience of thousands having had congenital heart surgery and who grow up to be adults. Gary Webb initiated the program along with my mentor, Bill Williams, the surgeon, for adult congenital patients in Toronto. Gary became a luminary in the field, much like Joe Perloff. But I can tell you this, when we went to meetings, and there was a big congenital meeting that part of the time was held in Toronto and part of the time was held in Oregon. When we went to those meetings, Joe Perloff was clearly the dean. He was the dean of the Big Four. And I know for a fact that Gary Webb initiated the Toronto program and looked to UCLA in terms of how to think about it, how to establish an adult congenital program, how to turn it into a leading academic adult congenital institution. What I would say is this: Joe Perloff and UCLA broke the way. Toronto, which became an important player in congenital heart disease, looked to learn from Joe Perloff and UCLA.
So many of our patients have undergone cardiac surgical procedures, and many have undergone more than one surgery in a lifetime. So we would be remiss if we didn't focus a segment on the evolution of cardiac surgery for congenital heart disease, specific focus on adult congenital heart disease, and really a specific focus on the unbelievable 49-year career of Dr. Hillel Lax. So without further ado, let's go ahead and roll this segment on congenital cardiac surgery here at UCLA.
I came to UCLA when Dr. Lax had really reached the peak of congenital heart surgery at UCLA. We were doing almost 500 surgeries a year. Our expectation was good outcomes, regardless of how complex it was, because Dr. Lax is such an amazing, talented surgeon and very dedicated to the outcomes of his patients. I don't think I've ever seen someone spend a full 24 hours in an operating room without a break other than Hillel Lax. And he does that because he is truly dedicated to the outcomes of his patients and really wants to make sure that everything he can possibly do, he does.
You know, motivations can take various forms, and the way that I have come to think about it is that it's like having a central fire and then having satellite fires which are kept alight by the central fire. The central fire, as I see it, has got to be a profound consciousness of the infinite value of a human life and of a human being. And from that consciousness come the other motivations. As a surgeon, one of the main motivations is to aim for perfection, to try to make the right decision to operate with the help of your team, particularly the cardiologist, to do a perfect operation, to give perfect post-operative care, and to have a patient leave the hospital with a really good operation that gives them the best chance of having a good life. Another of those fires is the desire to perfect your outcomes, and that means that you do not accept things as they are. That means that every complication, every death, every inadequate result is not just as accepted, well, this is what happens in this operation and everybody else gets it, and therefore that's how you have to live with it. The idea is to say, how are we going to stop that? Is it going to be a change in the operation, a different operation, or no operation, and find some other technique to handle it? And that desire to improve things and not to accept things, I think, in some people will result, sometimes even subconsciously, with coming out with a solution because your mind is constantly struggling with a desire to make things better. So that is an important fire, particularly in the field of congenital heart surgery, because there are so many variations in the anatomy, in the individual story of a patient, so that each time you're operating on a patient, in a way, you are doing something different and new to almost every other patient. The other fire, which needs to be a strong source of motivation, is to realize that you can't do it all on your own, and that if you are going to further the field and get the optimal results, you have to have a team around you that is superb and that have the same motivation, and that you work together to come up with solutions.
It was in Dr. Lax that I saw an example of somebody that fully understood and mastered diagnostic cardiology and a full understanding of hemodynamics and physiology, yet still did these awesome procedures, awesome surgeries in his case, that completely changed the outcome of these patients.
One of the major advances in congenital heart surgery, and a great achievement, came about because of the combination of the ability of adult congenital heart cardiologists to follow patients and to see the late sequelae of operations, sometimes decades later. And that was the case for the patients with transposition of the great arteries. When I came to UCLA, the standard operation was a mustard, and then we began to do setting operations. It was a low-risk operation, which we had a mortality of 1%, and the patients did very well post-operatively initially, and we thought this was a great operation. However, the adult congenital heart patients were coming to the clinic decades later. Some of them had now developed right ventricular failure because that was now pumping through the body. And others had developed severe tricuspid regurgitation, and the combination of the two resulted in severe heart failure. So, you know, when I came to UCLA, I started at the end of 1981 was my first surgery. At that time, although the first transplant had been done in 1967, because there was inadequate immunosuppression and patients were dying from complications, all the programs in the United States, or almost all, stopped except for Stanford. And in 1982, they began to use cyclosporin, which made a huge difference. And we then decided at that point that we should start a program. And in 1984, we did our first transplant. That was the first transplant in Southern California, and so a lot of patients were referred to us. And the program built quite rapidly. We had a superb team of cardiologists. We started considering doing adult congenitals and younger congenitals who needed a transplant. Doing adult congenital heart patients was very challenging, and all over the country the results had a high mortality. Rather than getting too restrictive, we tried to concentrate on how we could optimize the results. So our cardiologists developed techniques of methods of lowering pulmonary artery pressures with months of vasodilators, treating the heart failure very aggressively so that the liver and kidney were less congested. And surgically, we developed techniques that we had the chest completely dry and everything reconstructed before putting the heart in the chest so that it wouldn't be reworn by all the blood pouring from the surfaces, and there'd be minimal bleeding coming off. And our results were actually very good. For certain patients, groups, they were higher, but still the risk-benefit ratio strongly supported taking these high-risk groups of patients.
My name's Ken Boyko. I was born June 27th, 1951. And I was born with tetralogy flow. Back then, I think it was something nobody really knew what was going on at that point. And then in 1960, I had my first heart surgery. So I came here in 1983, and my first surgery was with Dr. Lax. And then they told me then that it was a tissue valve and should last 10 to 15 years, we really don't know. And it was almost 10 years to the date. So in 1994, Dr. Lax put another valve in and got a new heart in October 29th, 2014. And if it wasn't for Dr. Perloff, Dr. Childs, Jamil, Dr. Lax, Dr. Shannon, Dr. Moore, G. Money, Dr. Reardon, I wouldn't be here.
And I let everybody know I'm David Highfill. I'm your social worker. I'm 52 years old. I was born back in 1967 when transplant was brand new, and at that time I was told I was 3 months waiting in ICU for recovery. So lo and behold, I was fortunate enough being born with tricuspid atresia, an ASD, a VSD, a pulmonary stenosis, and transposition, that fortunately each of those defects worked in such a configuration that allowed me to live more or less as normal a life as I possibly could. I was limited in long distance running, in endurance types of things, but I was able to participate in almost every activity. But I found other ways to kind of make my way. But my first surgery, luckily enough, was not until I was 22 years old. And I had come down here to UCLA and at that time talked to first Dr. Williams, then Drs. Perloff and Dr. Child, and was convinced to move forward with the Fontan, which I then had in May of 1990 when I was 22 years old. And that lasted me another 22 years. And I was fortunate enough to hold on to my Fontan and make it work through a number of medication changes and different symptoms on and off. But my next surgery was the transplant at age 44, also here at UCLA in 2012.
Most patients do not require heart transplantation or multi-organ transplantation. Starting really in the early 1980s when Dr. Lax came to UCLA and actually put UCLA on the map when it comes to heart transplant and started doing the first heart transplantations here, including the first heart transplantations in folks born with congenital heart disease. that set us on a course to become a transplant center and a go-to transplant center for those with congenital heart disease. And we've taken that very seriously.
That was great. We're going to move on to our next segment, which really pays a tribute to really taking care of the whole patient. We're not just fixing the heart, and it's not all about just the cardiac issues, but looking after a lifelong need for congenital cardiology care. The nurse's role, particularly in that, and trying to address really the things that require patients to maintain a central connection with the healthcare system. So we're going to back-to-back two segments here. The first is on the nurse's role. And nursing has evolved even at UCLA to include clinical nurse specialists, nurse practitioners, RN care coordinators. And more recently, we've been joined by a social worker, David, who you met in the last segment, in order to really hone in on what those psychological needs are so that we're addressing those needs going forward and patients are getting the full care required. The follow-up segment to this is all about transition, again looking at lifelong care and making sure that the patients don't believe that their early childhood surgery was their cure and they don't disappear as adolescents or young adults and run into trouble. So you'll see some of our team that really focuses on transition. In both these areas, nursing care and transition were well recognized by Dr. Perloff early on as being key components of the Adult Congenital Heart Disease Center. So we'll roll those two segments now.
Dr. Perloff, to give him credit, he really saw, he didn't understand it, but he really could see the value that what an advanced practice nurse brings to this program, to this structure. We know we need a cardiologist, we know we need echocardiography, we know we need imaging, we know we need laboratory studies and diagnostic studies. So that's all part of every program. But what he valued was also what the emotional impact this disease had and how the role of the advanced practice nurse helps to identify that and then helps to try and problem solve it with the team. That is a real first for this program. It was very innovative that this program, when it was organized, the basic team was not just cardiologist, but an advanced practice nurse. As the program evolved over those first 10 years, there were changes, there were challenges, there were always challenges, but he felt so committed to that role that he made efforts to bring other people, such as Mava Day and then Pam Miner. So there has always been an advanced practice role here, and he always valued it, and he demonstrated to the other physicians that the role was essential to the success of the program.
I'd like to thank Mary Canobbio for her inspiring introduction to adult congenital heart disease 29 years ago when I entered this field at her urging. She saw something in me that I probably didn't see in myself, and I thank her because it's been the career of a lifetime. I also want to thank my collaborators, the nurse practitioners that have come since my beginning. First and foremost, Linda Hauser, who joined us in 2003, relieving me from being the only one there with an extraordinarily large patient population, and was my partner in taking care of these patients for 15 years before she retired. Katrina Whalen joined us 3 years ago, and Vanessa Kalis joined us 2 years ago, and Carolyn Moe joined us just this past spring. So we now have 3 very capable and eager to learn adult congenital heart disease nurse practitioners to lead our center forward.
When I first decided to come up and do a rotation at UCLA in adult congenital heart disease, my mentor at the time said to me, well, try to set this up and, try to get a hold of Dr. Child, he's the director. But really the person who is at this point, running the day-to-day activities of the program is the nurse practitioner, Pam Miner.
It was through Pam that I ended up arranging for my rotation. And really it was, from Pam that I learned so much about the day-to-day care of adult congenital patients, both inpatient care as well as long-term outpatient care, and building the types of relationships with patients and their families that can help sustain this kind of therapeutic enterprise for years and years. And I think I've benefited so much from that because Pam taught me how to become close in a very professional way, yet also a very personal way with my patients and their families. And now that I've been doing this as an attending for 15 years or so, I can tell you that the best part of the job, and the part of the job that really makes me come back and gives me pleasure in what I do, is when I have those personal relationships with families and patients. And so thank you, Pam, for doing that.
Fast forward to 2016, and I get an email from Pam telling me that, hey, the Adult Congenital Heart Association is providing accreditation, and as part of that accreditation, we need a clinical social worker on staff. So if you're interested still, we'd love to interview you. So lo and behold, this is kind of what manifested into where I am now. So I usually try to put people that are newly referred to me at ease right off the bat. Hey, I don't know if your doctor told you, but I'm also a patient. Huh? You are? And so, the lights come on, everything you can kind of just almost see them take a sigh of relief and like, oh, then you know what I'm talking about. It's really kind of a golden ticket. I think we all look at our congenital experience as, can I beat this? Can I be the one who lives the longest with the crummy anatomy that I have? Can I beat all the records? So I respect that, and I get that out there as well in my counseling with my patients or in the group or whatever the arena might be. But I understand and appreciate everybody's race against time, if you will, that we all want to succeed in our own way.
And I think that the more important factor that we sometimes ignore is, how do we make this person's life as normal as possible? And I am very fond of telling people when they tell me, well, I never exercise because I might die suddenly. And I'll tell them, well, you're living your death, not your life. You had a lot of interventions done and you've gone through a lot personally, and it's really important that all of that leads to you living as normal a life as possible. And if you find you're not doing something because of a fear of sudden death or because of a fear of something bad happening, then I'm not doing my job. My job is to minimize that risk as much as possible and let you lead that normal life. The holy grail of intervening for congenital heart disease is making that child a normal adult.
So it is, I think, threefold in that we're dealing with anxiety, depression, and trauma. And I can say that I have experienced all three of those myself in my own congenital career, if you will, that they are not to be minimized, and I try to understand and be with the patients wherever they are in this process and very much reflect back an appreciation of that and value that for them, and find the strengths within whatever they're talking about to help pull them forward through wherever they are.
So I was born with pulmonary stenosis, and it wasn't something that I found profoundly impacted my life until I went to college and took an EMT class and met a young girl who was undergoing a Fontan procedure when I decided that maybe medicine would be my future. And what I have discovered over the years has been that it's been an incredible gift in a way that I connect with patients on a personal level because we share a part of the same story. So I became interested in transition because I'm dual trained in pediatrics and internal medicine and also trained in pediatric cardiology and adult congenital heart disease. Bridging that gap from young adolescence to young adulthood is such an important part of development in terms of patients taking responsibility for their own health care. And I think that giving them that helping hand is really important to taking care of themselves.
I was one of the I guess, founding patients at the Adult Congenital Heart Center at UCLA. And over the next few months met John Child and Mary Canobbio. I've only been under the care of Dr. Perloff and the Adult Congenital Heart Center for a short time. When Dr. Perloff told me there was new surgery that might be available to me, a surgeon was moving to Los Angeles, to UCLA from Boston, who would perform what was called the Fontan. And this would give me more endurance, change my color, give me more oxygen in my blood. After my Fontan, things were really good for a few years. I had more energy, I had to keep up with my friends better, I was pink, and things were fantastic. I was also inspired working with Dr. Perloff and Dr. Child and Mary Canobbio, and decided maybe I should become a physician. So I decided to go back to college. I enrolled at UC San Diego and got my pre-medical requirements over a year and a half, and then was able to go to UC Davis Medical School. And now this was probably about 6 or 7 years after my initial Fontan procedure. I began to get a lot of arrhythmias. In medical school, they became pretty persistent. It did give me a new appreciation for Dr. Perloff and Dr. Child and Mary Canobbio, because I remember going to an adult cardiologist with a tachycardia when I was in medical school and having to explain to him what a Fontan was. And once again, this was before there was widespread adult congenital heart centers everywhere, when most adult cardiologists knew absolutely nothing about congenital heart disease. But I finished medical school, and then I did a pediatric residency at UCLA. But throughout this time, my rhythm problems got worse and worse and worse. I probably underwent 10 or 15 ablations over a 2-year period, none of which were at least successful for the long term. And finally, during my second year of pediatric residency, I underwent my Fontan revision, which was conversion of my classic Fontan, which was the cause of most of my arrhythmias, into what's called a lateral tunnel Fontan. And that did very well for me. I finished my pediatric residency and did a fellowship in pediatric cardiology at UCLA.
I think I would be remiss if I didn't mention David Atkinson as both inspiration and a demonstration of how amazing congenital heart intervention is. David had congenital heart disease, was told early on that there was no hope. By sheer luck, he met Joe Perloff, and Joe talked him into getting an evaluation to see if he could have intervention, which was a Fontan. David then became a pediatric cardiologist. And he took this, there's nothing we can do to improve your life, and turn it around and made it, you are now doing that for other people. And I think that he, in my mind, is the embodiment of where we were and where we are. When I look at all the patients that I see, I aspire for them to have the kind of life that David Atkinson has had. And a lot of people had a lot to do with that, but I credit Joe Perloff and the Adult Congenital Program with really taking people like David Atkinson and completely changing their lives.
What I want to share is just gratitude. I want to share gratitude for the people that have come before me and have taught me medicine and cardiology, the nurse practitioners such as Pam Miner and Linda Hauser, who took me under their wings and taught me congenital heart disease when I was really just a new cardiologist. Dr. Child, who always reminded me to tell patients to realize that they shouldn't be worried unless he looked worried. And to Dr. Abel Holson, who always is ready for battle and is ready to do the best for every patient that is around.
This whole industry, the word practicing medicine, practicing is what it is. You know, hey, we gotta keep trying until we get something that works. And I just happen to be, I think, at the front lines of all this, and amazingly, I've come to be 69 years old, which is, I remember they told my parents that I wouldn't live past 10. And that's freaking amazing. I mean, my mom and dad, to me, had the biggest balls on earth. I don't think I could put my son through what I went through. I mean, I just can't even imagine what they went through. And I can't even imagine what my family's been through, my wife and my kids, you know. I always said this was tougher on them than me. And it's unbelievable. It's literally unbelievable that I'm here to be able to do this video.
Well, those were two very inspiring segments. It's wonderful for us to see some of our legacy patients, including the story of Dr. David Atkinson, which is just an unbelievable story. One correction, though, to the title. Dr. Atkinson is actually a pediatric cardiologist currently practicing at Harbor, UCLA. He's not the chief of congenital cardiac surgery. That is currently Dr. Glenn Van Arsdale. So sorry for the mislabel there. Dr. Atkinson, you're far too cerebral, frankly, to be a surgeon. Just kidding. I would like to, before we go on to the next segment, just also let the audience know, please enter any questions that you have for the panel that we will have at the conclusion of the documentary portion of this show and these interviews. We would love to answer some of your questions, and we have a lot of people here physically today that are going to stick around to do exactly that. But without further ado, I want to go to our next segment, which is one that's very near and dear to my heart, and it deals with what we call the transcatheter revolution. So what is the transcatheter revolution? Well, it is the use of minimally invasive technologies, basically using small catheters, which are long tubes, to perform various procedures that once upon a time required open heart surgery. So many of you have had transcatheter procedures, diagnostic catheterization. Many of you have had stents placed, device closures, transcatheter valves more recently, and not to mention the real sea change that we've had in the management of rhythm problems of the heart with arrhythmia management using catheters, electrophysiology studies that Dr. Shannon and Dr. Moore and their colleagues do, as well as the placement of pacemakers and such. So really over the last 25 to 30 years, we've seen this rise in transcatheter technology and the use of transcatheter technology, and nowhere is it really more obvious than in the treatment of adult congenital heart patients. So let's start the next segment and enjoy.
Well above 50% of our patients as they age suffer from heart rhythm problems, either hearts that beat too fast and erratically, or those that beat too slowly and require pacemakers, or patients that may have dangerous arrhythmias that require defibrillators to be placed, or those that have dyssynchrony, a lack of synchronicity in the electrical timing of the heart that leads to the heart being an inefficient pump. And what we've seen, again, over the last 25 years is this growth in electrophysiology as an independent field, and really the growth of congenital electrophysiology as the most complex form of electrophysiology being practiced. There's nothing more difficult in the world of electrophysiology than attempting to do an ablation on a complex congenital patient who, say, has a Fontan or has the mustard operation. And what we've seen over the last 2 decades is the development of that specialty, and really over the last 10 years, the honing of skills of our electrophysiologists to provide that kind of electrical management of these patients that has helped sustain them, allow them to live longer lives and better quality lives.
In 1994, when I finished my fellowship and joined the faculty of UCLA, Joe Perloff asked me to come to the adult congenital clinic from time to time to see patients who might have arrhythmias. I was very excited to do that because, just being in the same room with Joe Perloff, you got smarter by osmosis. Almost everything he said was a pearl. And so I really enjoyed going to the clinic and learning from Joe. Joe had recognized that arrhythmia was becoming a major problem in survivors of congenital heart disease into adulthood. And he really thought it was going to become a field of its own very soon. There's always been a connection between congenital heart surgery and arrhythmias, primarily because of obvious damage to the conduction system, primarily heart block, but also sick sinus syndrome. The need for pacemakers was recognized very early in congenital heart surgery when patients had to be connected to these massive machines that would provide pacing. And Earl Bakken developed the first implantable pacemaker because of a 10-year-old girl who passed away when the power failed. So pacemakers were invented because of congenital heart surgery. In 1988 or 89, they started doing radiofrequency ablations at UCLA. Bill Stevenson was at UCLA at that time, and I always consider myself really fortunate to have had the opportunity to work with him and Joe Perloff, 2 giants in the field of congenital heart disease and complex arrhythmia ablations. Bill Stevenson had worked out that atrial flutter was actually dependent on a channel somewhere in the upper chamber of the heart, and if you could interrupt that channel, then you could cure atrial flutter. And so that became something we tried to do on a regular basis with relatively low success rates. I remember quoting patients, 50 to 60% chance of success for atrial flutter in congenital heart disease. Those numbers have improved dramatically with the new technology, 3-dimensional mapping systems, better energy delivery systems like irrigated catheters and cryoablation. And now we're quoting, 80% success rates for atrial fibrillation, even in complex congenital heart disease, and more like 90-95% success rates in atrial flutter in congenital heart disease, even in the kind of nightmare scenarios of Fontan with lots of scarring and multiple circuits. We can now really offer a very high probability of a successful procedure.
The transcatheter revolution really started more than 2 decades ago, but sped up in earnest starting about 15 years ago. Initially with the development of various balloons that could be used to open up narrowed valves or narrowed arteries, and early generation closure devices that could be used to close holes in the heart or abnormal vascular communications. And that's where things started. But what has happened really over the past 2 decades is we've seen a logarithmic growth in the number of defects and lesions that can be treated using minimally invasive techniques, using just catheters alone, or catheters combined with minimally invasive surgical approaches. So, for example, if you needed a pulmonary valve replacement, if you had tetralogy of Fallot and needed a pulmonary valve replacement in 2002, you would have required a surgical pulmonary valve replacement, which would have required the opening of the chest and placement on a heart-lung machine for bypass. Nowadays, with the availability of transcatheter valves, we're able to do the same type of valve replacement in a shorter time, get you home the next day, and you're up and walking around the next day, and you're usually back at work, if it's a desk job, within a few days. And what we've seen is that over the last decade, really, that field has now taken off and has become the standard of care for many patients with valve problems and with other issues that previously required a much more extensive surgical approach. So I think the future of transcatheter technology is that it will become an even more dominant area within the treatment of congenital heart disease patients. And I actually see surgery itself changing in some ways to become less invasive as we have greater availability of robotics, of tools, for example, that allow you to suture inside the heart and repair valves and close holes in the heart, again, through a small keyhole approach in the vein in the leg, or through a small approach, keyhole approach under the left breast, for example. And I see that our surgical colleagues will be doing a lot more of this minimally invasive work. Now, I do have to stop myself for a moment, and there's a caveat here. And the caveat is that all of this less invasive transcatheter stuff sounds great. You know, I love it. This is what I do. I believe in it. And I do think it's the future. However, there are those patients that need open chest, open heart surgery, the traditional surgical approaches. And what we need are surgeons that can still do that kind of work in the same way and with the same excellence that Dr. Lax brought and that Dr. Van Arsdale brings now. And so I think, you know, the future of cardiac surgery is going to be, yes, more of a move towards these less invasive ways of doing things that can be done in less invasive ways, but also continuing to have mastery of these surgical techniques that allow them to take care of patients that we just cannot take care of in the cath lab. And I think we will always have a need for that kind of surgical technique and excellence.
Well, we've come to our final presentation as part of our formal program. And this one really is the national perspective in adult congenital heart disease and how it has impacted practice at UCLA, but also where we see adult congenital cardiology care going in the future. So from a national perspective, we look at center accreditation and training of our next generation of providers, as well as board certification, and really look at where the guidelines for care of this population came from on the national front. And throughout this segment, you'll get a good sense of how we see the future unfolding. So we'll go ahead and roll this segment.
The Adult Congenital Heart Association started an accreditation program for adult congenital programs back in 2015. Or so. And UCLA was one of the first batch of programs that received an accreditation as a comprehensive care program, which essentially means a level 1 highest level kind of program. It would be akin to the letter A on a restaurant, showing that we have the procedures and the processes and the staffing in order to deliver the highest quality care. And that was a huge step forward for this field. And the reason I say that is that before we had program accreditation, we had a hodgepodge of programs around the country, each kind of doing their own thing in their own way and delivering care in various ways. After 2015, we had to standardize our processes and procedures in order to deliver care in a rapid manner. So for example, a patient who calls and needs to be seen urgently as an outpatient should be seen within 2 days. If a patient gets admitted into the hospital and an adult congenital consult is needed, then the patient needs to be seen within 24 hours. If a patient calls in the middle of the night on a Sunday night because they're having a problem, they shouldn't have to speak to somebody who has no experience or no specialization in this area. So now we have 24/7 coverage, 365 days a year, by our fellows and our attendings who are specialized in adult congenital heart disease, and so on and so forth. Accreditation really elevated not just UCLA, but numerous other programs around the country to give us a certain standard that we now meet, and in our case, we try to even exceed that. But patients should know that if they come to comprehensive care programs that have that accreditation through the ACHA, that they are selecting a program that has all of the bells and whistles to provide world-class care, 24/7 availability of specialists, and 24/7 availability of operating rooms and cath labs, should those be needed for the care of the patient. I mean, really, you have three ways of supporting a program, an adult congenital program. One is through clinical billing, which one must do. Two is through philanthropic contributions, and that's where, honestly, we've had a lot of help from patients and friends and supporters of the program over the years, and the program would not be what it is today, and frankly would probably not have survived those early years had it not been for philanthropy. And then the third part of it is grant funding that we can bring in through various agencies, national agencies as well as local agencies. So for us at the UCLA ACHD program, we look at all of those three areas, and every year we're looking at how can we bring in resources from those three major areas for us to be able to support the program that we have, but also grow the program. You know why? Because our patient volume is growing. And so we have to be able to increase the number of providers, the number of clinic slots, etc. But we also need to keep up with the times and try to be ahead of the times a little bit when it comes to the sorts of services that we offer. So for example, bringing on a social worker. That is something that we wouldn't have dreamt of 15 years ago, but a few years ago, we were able to do that with David Highfill by showing the hospital here, the health system, that we were worth it. And so they were then willing to support us to bring on some new staff and some new faculty in order to meet accreditation standards.
So ACHD training in the 2000s and the early 2010s was very informal in most places. Here at UCLA, my own fellowship was a year long, and it was very much this apprenticeship style of training where you learn from the mentors and you followed them around. They gave you a lot of teaching on the fly. You did a lot of learning on your own, and it was an amazing experience, and I learned so much from both Dr. Child and Dr. Abelhusen. Things have changed a lot in how we train our future adult congenital heart disease colleagues since then, and there has been a major shift to formalizing the ACHD fellowships across the country. We at UCLA, of course, have evolved our own fellowship in line with that and have been a 2-year fellowship since 2016 and have trained a number of just really wonderful adult congenital heart disease cardiologists just in the short time that I've been the program director of the fellowship.
Well, the question is, what was it like to put together those guidelines in 2008? The guidelines for adult congenital heart disease, also known as the guidelines from hell. Carol Warnes and I co-chaired that group, which was wonderful. We had collaboration from the most fantastic group of champions and experts. And at the end, when we pulled it together, it was such a triumph of collaboration. And so Carol and I sort of divvied up, and I did the final writing on the first half, she did the second half, and it's been something we've been very proud of all these years. The process of putting together the first board exam for adult congenital heart disease started with the help of the ACC when we had to really convince the American Board of Internal Medicine and the American Board of Pediatrics that this was important and actionable. That took quite a number of years, and people like Mike Landsberg and John Child and many others were very, very helpful with that. And so when we finally were able to put it together, we had a committee of 6. We had 2 adult congenital heart specialists from internal medicine. We had 2 adult congenital heart specialists from pediatric cardiology. And 2 of us were med-peds. And so we made a test that had enough hard questions on embryology to cause the adult cardiologists to furrow their brow, and enough questions about superimposed acquired cardiovascular disease to frighten the pediatric cardiologists. And I think it turned out to be very, very well balanced, because you really need all of that information and understanding to take care of adults with congenital heart disease as fully as possible.
A lot of the other people who have been part of this presentation today have talked about that drive, that motivation to be the best. And what makes me really incredibly proud to be part of this team is knowing that the care that we provide to our patients is the best care that an adult congenital heart disease patient could get anywhere in the world. There may be care as good in other places, but I would challenge someone to find a place with better care than what we have here.
To me, 40 years has gone past so fast, and the adult congenital clinic at UCLA is second to none. It's the one that created what's going on in America, if not the world. 40 years is incredible. And I think Dr. Perloff would be, he's up there looking down, proud as hell.
I've been lucky enough to be part of the UCLA adult congenital program now for 2 years. And I'll say this: the precedent set by Joe Perloff, the beginnings that began so many years ago, have now resulted in a phenomenal team. I didn't build it. I can't take any credit for it. I'm an outsider who walked in the door and had a chance to see what's happening. Here's what's happening. Because of Joe Perloff's leadership and what he started so many years ago, and the leadership of Hill Lax, what those two did together, today, UCLA takes the most complex of the most complex patients around the country. That team says, we don't give up. The adult congenital team says, how do we make it better? How do we take the impossible and turn it into the possible? How do we take the inevitable and turn it into continuation of life? So my hat's off to Joe Perloff, my hat's off to Hill Lax, my hat's off to this adult congenital team that doesn't say no, that doesn't give up, and that keeps pushing. And the credit at the beginning has to go to Joe Perloff.
Well, I hope everybody enjoyed those interviews, that hopefully this footage will be valuable for many, many years to come. And I can't wait hopefully I'm around many years later to look back at this to remind us of where we are now and where we came from. You know, when I first came here to UCLA and joined the center as a fellow, Dr. John Child was the director of the center and really took me under his wing. And Dr. Child retired from practice about 8 years ago, but he continues to come back every month, and sometimes multiple times a month actually, to teach our fellows about adult congenital heart disease and the various aspects of adult congenital heart disease. So a special thank you to Dr. Child for doing that. What I'd like to ask Dr. Child is, how do you see adult congenital interest in our trainees compared to those early years when the field was first starting, now that the field has matured over the last 40 years? And where do you see things going over the next decade when it comes to stimulating interest in those young minds, in medical students, in residents, in fellows, in nurses and nurse practitioners to join this field? So let's go to Dr. Child.
That's a big question, a big order. What I come back for is the enjoyment of seeing the trainees, the cardiology fellows, whoever, seeing some of the basics. Much of what I teach them has to do with either the physical diagnosis or a historical fact or some major echo or imaging type of feature. The thing I'm not qualified to do, because I haven't done it, but we have here the expert, is all of the transcatheter information, techniques, and skills that takes. I think procedural things such as that often are what attracts fellows into the fold of doing this sort of thing. But hidden under that, I think that them seeing, just as I mentioned at an earlier phase of this program, the Sherlock Holmesian side of things, I think the people with inquisitive minds who like to do puzzles, to see the pieces of information lie down in a logical fashion, to come out with a logical outcome and then a determination of what to do for that problem, is what attracts many of the inquiring minds that come into cardiology in the first place. But I do think that the fact that they can see things that they themselves now can do directly, other than, let's say, giving a medication, which everybody thinks is simple, but it's not. I think that's what attracts many of the fellows to the field, is that they now become sort of the pseudo-surgeon in doing all of the things that congenital cardiology now require as expertise. Where do I see things going? I don't know. I'm not much of a visionary, probably. I think that right now the UCLA program, as an example, is on the right track of how they train fellows, how they lead the way for them to evolve their own thoughts, their own ideas, their own research. Simple answer, maybe. Do you have comments that might?
Oh, well, thank you. No, I think that's wonderful. And you know, I remember my early days here and how valuable that type of teaching was for me, giving me the basic structure and then layering. And you did that in, and I think it takes a lot of talent to do that, where someone who has such a high understanding, such a complex understanding of the nuances of the field can actually teach you the basics and then build you up thereafter, layer by layer, to the point where you can actually begin to master the field. So I thank you for that, Dr. Child.
We've got a few questions from the audience, which we're happy to go to shortly. Thank you for participating in our Q&A. I'd like to ask Mary Canobbio to come to the microphone, because we've seen through all of your lovely comments throughout this presentation, both of gratitude but also recognition of the providers that have taken care of you over the years. There's definitely a theme amongst young women who have had babies and were told as children themselves that they shouldn't ever think about having a pregnancy because they have serious heart problems. And Mary, I think many of you young moms know, really helped set the pace of how we find out how to take care of these pregnant women who have congenital heart disease and what types of care need to be taken to make sure they get through and their babies get through these high-risk pregnancies. So Mary, I'm going to ask you to comment a little bit on how you saw this as a major need and kind of how your experience has transformed the care of high-risk women in pregnancy.
Well, I think, again, we have to owe this back to Dr. Perloff, because his vision, as I said in my piece earlier, that he saw that congenital heart disease impacted the lives of people on many levels and in other specialties and non-cardiac specialties, and he drew those people to us, to our program. And none was bigger than the area of reproductive health for women with congenital heart disease. And so very early on, I mean, within months, we knew we needed to have an obstetrical team to take care of and counsel these patients and help us with them. And then I have to say that when the Fontan procedure was done and with Dr. Lack's arrival, everything really changed, because suddenly these patients who had been told that they couldn't get pregnant, I will give you the quick story that I gave. I had a patient, she was cyanotic, she had cuspid atresia, and we kept telling her she couldn't have a child, she couldn't have it, would be high risk, and so forth. So Dr. Lax came in, and she was one of his first 10, and about a few weeks after she finally got the clearance, her post-op clearance, and she was fine, she says, "Mary, I want to see you." And so I said, "Okay, what?" She goes, "I'm not blue anymore. When can I get pregnant?" So almost immediately, we knew that this was going to be a growing field. And I have to say that UCLA, this adult congenital heart program, has taken the leadership in many ways, certainly in reproductive issues, menstrual patterns, and certainly in pregnancy and high risk. So again, it goes back to day one from the time this program was developed, and has only exceeded and done incredible amount of work in this area. So I'm very proud to have been part of this program.
Your role as a researcher is unparalleled over the last 3 decades of looking at these high-risk populations and collaborating with other centers that have a lot of patients, because this is a specialty in which we need to have multiple centers weigh in for us to really make consequential impact on recommendations for care. And your papers on the women with Fontan and the women with mustard and Sennings, and where, what are the highest risk issues and how do we take care of them, are, groundbreaking, as well as the guidelines on really how best to approach this high-risk population. So we thank you, Mary, for continuing to strive to keep pushing us forward.
Thank you for the opportunity.
All right. You want to?
Thank you so much, Mary. The next question is for Dr. Lee Reardon, if you don't mind stepping up to the microphone. And it actually relates to an area that Mary Canobbio helped initiate here at UCLA, and that Dr. Reardon now directs, which is transitional care from childhood and adolescence into adult care. And you talked quite a bit about it during the documentary portion, but what we'd like to ask you is to speak a little bit about Camp del Corazon and the PACES program that you're very involved with, and that Dr. Kevin Shannon helped to found, along with Lisa Knight, who passed away unfortunately last year. We lost her. But can you talk a little bit to the audience about the importance of Camp del Corazon and the PACES program, and how you see that fitting into the transition model, and where you think that needs to go going forward?
Thanks, Jamil. I'm really committed to transition and lifelong care of patients, and going to what Mary was talking about in terms of pregnancy and people having realistic perceptions of how they can move forward in their lives, and also maybe expecting things like heart transplant in the future. Camp del Corazon was founded over 20 years ago by Lisa Knight and Kevin Shannon, and their camp names are Kahuna and Zena. And we lost Zena about a year and a half ago, and we really miss her. But her legacy lives on, because what it has created is that congenital heart disease just isn't a condition that you go to a hospital or you go to a clinic to take care of. It really impacts your life in many different facets. And what Kevin and Lisa really realized was that you needed a community in order to sort of heal those other wounds and to develop an understanding about your congenital heart disease and how it integrates into your life. And Camp Del Corazon is really a program that started off as a camp for children between ages of 7 and 17, which was a on-site camp for about 5 days. And one of the most impactful sort of experiences that I had at Camp Del Corazon was a couple in 2 years being the camp doctor. Some of the kids noticed my own scar, and one of the 16-year-olds sort of turned to me and she told me that I had street cred. And it was a really touching moment. And I also got really involved in the PACE program, which stands for Progressive Adult Cardiac Experience. It used to be Progressive Adult Congenital Heart Disease Experience, but what we realized is that a lot of people that were participating in camp also had acquired heart disease or had heart transplants, and the community was really meant to be inclusive. And PACE is a program that, as more and more children went through Camp Del Corazon, they realized how much that community meant to those patients and how much there was still a service need. And so PACE is really for individuals between 18 and 25 years of age. And we kind of joke that it's camp or Adulting 101, where this continued community really teaches the participants to take charge of their health care, to how to ask tough questions of their doctors, like, can I get a tattoo? Can I have a child? Will I need a heart transplant? And our nurse practitioner, Katrina Whalen, affectionately known as Kit Kat, also helps sort of bridge that gap and help the entire community. And I think the important thing about Camp Del Corazon is it's not a UCLA organization, and it's meant for the entire congenital heart disease community. So we have patients primarily from Southern California, but we have patients from Washington and Boston and from all over the country that fly out to participate in these programs.
Thank you, Lee. Dr. Lurie, would you mind coming up to the microphone? We have a question from our audience about what do we know today about heritability of congenital heart disease? How many patients with congenital heart disease might have a child with congenital heart disease?
Thank you, Pam. That's actually a great question that we get a lot from our patients in clinic. And while in the general population, the risk is about 1 to 2% estimated, if one parent has a congenital heart disease, it is thought that the risk is about 3 to 5%. And that becomes very important for female patients with congenital heart disease who plan pregnancy in terms of risk stratification and so forth. So 3 to 5%. There are certain conditions where the genetic background is much more important, such as Marfan, where the risk is much, much higher. However, and if both parents have congenital heart disease, that the risk goes up to probably 10 to 15%. Those are like some of the numbers that we try to explain to the patients in clinic.
If there's more than one family member in a family, a primary family of father, son, sister, if there's more than one, how do we know yet kind of how that multiplies the risk?
Great question. It depends a lot on the specific congenital heart disease. Even though we give a range, for example, if we say 3 to 5%, 10 to 15%, but if there is definitely a family history, whether it's the siblings, cousins, then they would be in that higher number of that range that we would say that the patient.
Maybe you can say a word about our genetics cardiac program here at UCLA and how our patients might benefit from that?
Yes, and we do have a very robust genetics program with our colleagues here, Dr. Jessica Wang, where we refer the patients for a little bit more in-depth and detailed discussion with the patient about further risks and further testing that needs to be done.
Thank you.
Thank you.
Thank you. So the next question is for Dr. Jeanette Lin. If we could have Dr. Lin come up to the microphone. So Dr. Lin joined us and has really been a godsend when it comes to the organizational part of the program, and especially organizing and formalizing the fellowship training in adult congenital heart disease here at UCLA. She mentioned this a little bit in the documentary part of the program, and speaking about what training used to look like and how much more formalized training is now. What we'd like to ask Dr. Lin is how she sees this potentially impacting in a positive or potentially negative way the workforce in adult congenital heart disease, the physician workforce in adult congenital heart disease, and also for Dr. Lin to maybe speak a little bit about the future of training, what that could potentially look like, and also the possibility of training programs for mid-level providers like nurse practitioners and PAs in ACHD.
Thank you. That's a big and very broad question that I will do my best to answer. So one of our core missions here at UCLA, of course, include education. And education is important because we are on a mission here not just to take care of the patients at our center here at UCLA, but to make sure that congenital heart disease patients everywhere across the country and even around the world can get the best possible care. We are committed not just to the patients of our center, but adult congenital heart disease patients around the entire world. And so education is really an important part of what we do. And our patients are an integral part of that education with us, as you all know, having seen fellows and nurse practitioner students, nursing students, residents, medical students in the clinics and in the hospital with us. We train fellows then. We have 2 fellows in training at any given time with the idea that we want to expand access to care for congenital heart disease patients everywhere. And the people who have graduated from our fellowship here have gone on to practice around the country, and we also have collaborations with people who are practicing around the world now, and we're incredibly proud to share our knowledge and our experience with everybody. In terms of what the future needs are for training, we know that there is a tremendous need for more adult congenital heart disease providers everywhere. And we're very blessed to have the center that we have here in Los Angeles, but in large parts of even California, Northern California, some parts of the Central Coast, for example, patients don't have access to the same care that people who live immediately around us in Los Angeles do. So again, trying to expand the provider base and provide more access to care for everybody is very important, and that's an important part of our training. We need to train not just the physicians, but also nurses as well, and advanced care providers. That's very, very important. As you guys have heard over the program today, advanced care providers or practitioners are a really important part of any adult congenital heart disease center. So we have nursing students that rotate with us, nurse practitioner students that rotate with us as well, and all of that will help expand the workforce and help our patients have the best access to the best care.
Thank you, Dr.
Thank you.
Lin. We have a question that I think I will send to Dr. Abelhosen on does the Adult Congenital Heart Disease Center engage in research projects? What are their current projects or planned projects? We didn't get a lot into that into our presentation, but
Sure.
Perhaps you can touch upon that.
Yeah, so we have basically 3 core missions, and those are patient care, clinical care of patients and the provision of that care, teaching, which both Dr. Lin and Dr. Child spoke about, and finally research. And that research can take multiple forms. It can be clinical research, where we are looking at retrospective things that have happened, what happened over the last 30 years to certain patients, or prospective research, where we are looking at what happens to patients going forward, whether we give them one medication or a placebo, or we put a valve in them, or whatever the case may be. So that would all be under the clinical research umbrella, and we do a lot of clinical research. And then you go basically from there to more focused research on the cell, and then thereafter the contents of the cell, all the way down to RNA and DNA type research. And we call that bench research. And the Adult Congenital Heart Disease Center engages in research across the span, but with the major focus being on clinical research and clinical outcomes. One of our main areas of focus over the past decade has been research into novel interventional techniques, catheter-based interventions that we spoke about, both electrophysiologic as well as valve interventions. And at UCLA, you'll find that you will have access not just to the technology that's currently being utilized and that's currently FDA approved and available, but also to potentially be a part of studies into the next generation of valves and of devices. And so for those that are interested in participating in research studies, we do have numerous options for you. This research is performed by myself and many of the colleagues that you've met already, and wouldn't be possible, frankly, without our research infrastructure, which includes our research coordinators and our administrative managers, Yvonne Jose and Andrew Ewan, who are both here in the audience but have not come up on stage. So it takes really an entire infrastructure to successfully and safely do research, and UCLA focuses on that as one of our core missions.
This ties into that, this final question. We'll have to kind of take this as our final as we're wrapping up, but the question is, what does the UCLA Adult Congenital Heart Disease Center need to achieve going forward to realize the goals in research, practice, and care?
Well, you know, that's a really broad question. You know, this program that we did today is an educational program and a celebratory program of the achievements of the last 40 years. But in reality, those achievements would not have been possible without the philanthropic support of so many people, foundations, as well as UCLA Health. So in reality, in order for us to actually achieve our goals when it comes to training, when it comes to providing the highest level clinical care and doing the cutting edge research, is to bring in funds to be able to do those things. And so that is an area that we've been blessed to have patients, families, and others support us in doing. But that, I think, is what it's going to take, frankly, is the continued support of our many friends and colleagues and patients and their families for us to be able to achieve our long-term goals. And I think, actually, that's a great final question, Pam, because as we conclude here, we are going to have one last montage, which is a thank you to those that have supported the program over the many decades, without the support of whom none of this would be possible. So we will roll out with that. But before we do, I just want to give a final thank you to this lady here, Pam Miner. Thank you, Pam, for everything that you have done. And for not just retiring and taking off, but committing to putting this program together. She's done the lion's share of the work, as has Linda Hauser, who's actually in the audience as well. So thank you, Linda. All right, without further ado, let's roll that montage, and thank you so much for joining us.